Let's do a typical clinical case. You're called by the RN to see a patient on the general care floor, and when you arrive, you see an elderly female on 6 liters per minute oxygen, and she appears to have some increased work of breathing. Now, I'm going to go through this case similar to the way PBDS, the Performance-Based Development System, does it. Some hospitals use that to assess their people, or their new hires, rather. Okay, so first thing you'll do is perform a quick assessment. Do all the things that you can do easily, like take the respiratory rate. Hers is 32. Her heart rate is 112, crackles in the lower lobes. She is pink, although her saturation reads out 78%. She is a bit sleepy, has a weak non-productive cough. Blood pressure is okay at 110/57, and her temperature is normal. An interpretation of those results, the respiratory rate is a bit concerning at 32 breaths per minute. Anything above 28, you should be concerned. When you get as high as, say, 35 and 40, there's a real concern of respiratory failure. But the action here is to continue to monitor. Continuing with our interpretation of the vital signs, the heart rate over 100 is considered tachycardia, although probably not considered an emergency until it's up around 150. The patient does have crackles in the lower lobes, which is a nonspecific sign that could indicate a number of different things, including pneumonia and pulmonary edema. Again, that doesn't point to any specific therapy, so let's continue to monitor those. But we do have something that we need to perform an action on, and that is the SpO2 of 78%. Anything less than 90 is considered hypoxemia. Now I would recommend with a sat that low of increasing the FiO2 starting with 100% and work your way down. Continue to monitor the SpO2 and shoot for a target of around 92%. You can, if her oxygen shoots up, you can always take it off and reinstitute another form of oxygenation, possibly a high-flow system, since she is tachycardic and has increased work of breathing. The concern here is that you not over-oxygenate because you don't know her history yet. She could be a possible COPD patient, and as we know, SpO2s that get too high, say 98, 99, 100, could lead to oxygen-induced hypoventilation with these people. I'll just note that I'm not hesitant at all to put the non-rebreather on them as long as I'm able to monitor their SATs. Remember, your oxygen-induced hypoventilation occurs because of high oxygen in the blood and not because of what's on your face. Her neurostatus is a bit sleepy. There always is a concern that when you see a sleepy patient, that their carbon dioxide is elevated, since this could cause the patient to be somewhat obtunded. She has a weak non-productive cough. That may be something we have to deal with later. No immediate problem there, and blood pressure is fine. After performing your immediate actions, now you're going to gather more information as required. As in all PBDS tests, always be sure to notify someone, in this case RN and/or physician, of the immediate actions you performed. You might suggest, if you have not called the physician yet, performing an ABG. In some hospitals, the physician would have already expected you to do the ABG, so you can report that information before you call him. Check with your own facility's policies and procedures. Also, we should suggest calling for a chest x-ray. Also, make a quick review of the patient history. We can talk to the patient and the other healthcare workers in order to try and formulate an opinion. The blood gas is back, and it reveals two problems. One, and most importantly, is the oxygenation. The patient's PO2 is barely within range despite a very large FiO2. This means there's something wrong with the membrane of the lung and its ability to pass oxygen into the blood. You would expect a PaO2 of much higher. To figure it, go back to your alveolar air equation, but you'd expect a PO2 much higher than what you're seeing here on that much oxygen. The second problem is the fact that the patient has an increased work of breathing and a respiratory rate of 28, and that's what's required to keep her CO2 in normal range. On the basis of that blood gas, BiPAP or CPAP is indicated. When it requires a FiO2 of greater than 50 or 60% in order to have a PO2 of greater than 60, CPAP is definitely indicated. BiPAP is also indicated at the first sign of respiratory distress. The pressure support provided by the BiPAP helps the patient ventilate, improve their tidal volume.